If there are any questions, please put your hands up.
Can I just make a comment which actually applies to both of you? I had a patient who had a very bad injury, and it was a child, and she had a missing skull, but it wasn't that bad. It looked okay, and I said, look, you know, this is risky stuff. Why do you want it put back in? And Mum said, well, all her friends at school line up to poke her head so that the opposite arm moves like that. So we did the cranioplasty.
I don't see any hands up, so I'll just ask some questions if that's okay.
Oh, no,
we've got one, have we?
oh, yeah.
Okay. We've got the microphone, please. Yeah. It's coming.
I had radiotherapy because of my cancer. I had brain tumor, and my left eye nerve is damaged, so they called it bitemporal hemorrhagia. Is there any chance of like treating it? Like if I can get my vision back or something like that? That's all.
Alistair, do you want to field that one?
I think that the trouble is that what you've got is damage to the whole visual pathway is really irritating because it starts at the eye and then ends up being seen at the back of the head. So, you know, thanks God. And of course, it's vulnerable all the way back there. If you've got a bitemporal hemianopia, did you say? So your visual field is damaged out here?
Just on the corner.
Just on, okay, just on one.
Left side.
Just on one side, okay. Unfortunately, that, as you say, you had a tumor in your brain, and that will have permanently damaged the cells. If it's something on the pathway on the way there, then there's a chance it may be a bit of compression or something. But if it's the cells, the visual cortex, the bit of the brain that actually processes what the eye sees, I'm sorry to say I don't think there's anything I know of that will get it back. But ask Elon Musk in a few years and maybe he'll have something.
Thank you.
So, question up at the back there on the left.
I'll run up to that one.
My question is going to be directed to Mr. Canty and the professor from Newcastle, especially when you talked about a traumatic brain injury. I've heard about like the diffuse axonal injury that does come with some traumatic brain injury, especially when regards to peds and adults. What do we really know about recovery rate for diffuse axonal injuries, and how does it differ between adults and peds, if that is the case? And you know, it's like depending on who you're treating at a particular point in time. That is the main one I just wanted to know. And then the other one is, when you look at people who have a traumatic brain injury and using decompression as, you know, one of the options for treatment, is there anything we know, or do you reckon you see in the future where we can actually treat these people without decompression or kind of, you know, craniectomy? I mean, in terms of the decompression bit. And by these, I mean, in some instances, people, you know, like, a way of reducing like swelling in the brain without decompression, like for example, even reducing the body temperature or something like that, and trying also to save the brain cells by, you know, reducing the cytokines getting released when a brain is damaged, because I reckon the oxidative stress and stuff like that does happen. I'm just trying to think, is there anything we can do more to stop craniotomy, like decompression? Yeah, that is the second question. Thanks.
Okay, so in the first question, Michael, do you want to address the...
Yeah, sure. So diffuse axonal injury is one of those things that's incredibly heterogeneous. So we can see diffuse axonal injury so first of all, what it is, we're talking about injury to the deep white matter of the brain, so those hugely long axons that run from the surface of the brain down towards the brainstem and the spinal cord. And they're particularly vulnerable to twisting mechanisms of injury. So the classic sort of example is a motorcyclist who comes off and spins on the road will tend to get a diffuse axonal injury. And those are really, really damaging. You're talking about millions or billions of neurons that are damaged and connections that are lost. So they are generally more severe in the adult population because the recovery potential is less. And as I say, children's brains are more plastic. They have more plasticity. They have more ability not to regrow those damaged areas. They'll never regrow, but you can form new connections around them. And you know, some of the most amazing recoveries I've seen have been from diffuse axonal injuries, but they're hugely heterogeneous. We can see them just on a scan in someone who's actually pretty well, and we can see them looking on a scan not too bad in someone who's profoundly, profoundly injured and disabled. So it's a very peculiar and potentially very damaging sort of injury. Children in general do better. They're just better at recovering than we are.
The second part of the question was in decompressive craniectomy, which in fact you've all explored really in your talks, haven't you? And maybe we could talk a little bit about that and some of the controversies. Alistair, do you want to?
I think the two questions you asked are the absolute basis of head injury treatment and research, and you know, over the 45 years I spoke about. And the answer to both parts of the first question, is there anything that we can use that reduces pressure inside the head in order to try to prevent us having to take the lid off? The answer is yes. We already have things like that, and the two things that have been used over the years are mannitol, which is a sort of sugar-like thing, which draws fluid, because it's concentrated, it draws fluid out of the brain environment into the bloodstream, and then finally into the bladder. So as well as giving mannitol in one end, you have to remember to stick a catheter in the other end. And the other one is simply hypertonic saline, which works in exactly the same way, and each has their adherents. They're the best we have. They are probably as potent as they can be. So if it's purely to try to reduce swelling, I think we are limited. We've got that, and we've got decompressive craniectomy. Regarding oxidative stress and all the cascade of events that you probably remember from one of the slides I showed a couple of times there, that's where we're at in the scientific research. There are still chemicals being looked at, many years on from when it first started. And sadly, as Mike said, we haven't found the magic drug yet, but we're still looking.
Thank you. Michael, do you want to?
Yeah, I think that the really difficult thing to square in acute head injury is that we know the things that are really bad. So we know that raised pressure is very bad. We know that people with raised pressure do badly. But weirdly, reducing pressure often doesn't seem to make a difference. So we can reduce ICP in a severely injured brain, but over hundreds or thousands of patients, the difference seen is really, really minor, and we don't understand why that is. You mentioned temperature. There's been a big trial about, therapeutic hypothermia run from Edinburgh, and actually showed that patients, if anything, did slightly worse when you therapeutically cooled them. So the head injury literature is absolutely full of a whole pile of things that have been done that either make no difference or only a very, very small difference. And that's the great sort of challenge, I think, of working in that area.
So we've only got a couple of minutes left. I'd like to ask each of the panel members where they see future. We've seen an adult neurosurgery talk, a pediatric, and the reconstructive talk. And you've all touched on that, but maybe you could lay out for me and for the audience where you think this is likely to go over the next few years, few decades. We'll begin with you, Alistair, if that's okay.
I really don't know. You probably got the impression from my talk that although I'm also a glass half full person, I'm a little despondent about the future in head injury research. Everybody who's involved in it thinks there's got to be something around the corner, there's got to be something around the corner. But I think to some extent we're being naive, because primary injury is a very big thing. Even if you could eliminate secondary injury overnight, primary injury is still the one that gets you. And that's the Jeremy Clarkson thing. It's when the head hits the dashboard, the brain keeps moving, the skull stops, and it doesn't like that. I think one of the things that we can do, particularly in a country as small as this, is we can talk about prevention. And we can also talk about things like transport. Nobody's really talked about that. That helicopter I showed you, good and bad. There was, for instance, a study done in Liverpool which showed that having a specialized pediatric team picking up children from one hospital with a head injury, stabilizing them, taking them for surgery or treatment to a specialist neurosurgical hospital, the outcome was worse. Why? Because they spent too long farting around. And, you know, scoop and run seems to be the way to do it. And I think we need to look at things like transport, we need to look at things like efficiency, which we're not very good in the NHS. But no, I'm a bit gloomy.
Michael?
I thought you said it would be a softball question. I think, you know, I hate to use cycling analogies, but I think it's a question of marginal gains. I think it's about finding little things that make small amount of differences, plugging those into a huge network around people and seeing that make a difference on a population basis. Nothing will make more of a difference than prevention and public health strategies to reduce injuries happening in the first place. And then on the dealing with the rehabilitative aftermath, we all get very excited about the newest drug or the next way to measure ICP or lower ICP, but those things I don't think are quite as important. I mean, if trauma care in the 70s worldwide was, you know, massively different from place to place, you know, until an orthopedic surgeon crashed his plane in Nebraska and was horrified by the care he and his family got at their local hospital, and that was the kind of basis for ATLS, Advanced Trauma Life Support, and a standardized approach to trauma. And that's made a huge difference, and I think it's more of a systems-based approach from all members of the sort of interdisciplinary team that will chip away at the problem of head injury over time.
And David, finally, on the reconstructive side, where do you think the future lies?
Well, I suppose mine's quite easy. I think it's bioprosthetic implants are where we're going to be at. It's almost beggars belief that in the 21st century we still use big pieces of bent titanium or plastic to reconstruct skulls in the majority of cases around the world. And I think having a truly biocompatible, custom-grown implant for our patients is where we're going to be at in the next 25 years. And that'll be nice.
Okay, so first of all, I'd like to thank all the speakers for some really engaging and interesting talks, and thanks to you all for engaging.